Unpacking Decisions. This is a series which we've initiated to help people be better informed and understand the nuances of a challenging topic, a new topic, a difficult topic, and to support their effort to participate in shared decision making. Our hope is that this effort will help them arrive at decisions that resonate with their priorities and improve their quality of life. Um, Patients Engage is a platform that empowers people with chronic conditions and disabilities to engage better with their health and make informed decisions. We also advocate for more meaningful involvement of people living with long-term conditions in health systems decision making. I'm Aparna Mittal from Patients Engage, and today we are kickstarting the Unpacking series with a discussion with Dr. Hari Menon on a new and exciting innovation, the CAR-T. During the course of this conversation, we will unpack what CAR-T is, where it stands today, is it really what you think it is, and how we can take informed decisions on this new treatment. This is being live streamed, so if you post your questions, we will try and address them during the session, but if not, we'll try and get to them later. Before we begin, let me introduce our expert guest. Dr. Hari Menon is Professor Hematology and Head Medical Oncology at St. John's National Academy of Health Sciences in Bangalore. He has been in the field of medical oncology for more than 2 decades, starting with his training at AIMS in Delhi. He was faculty and professor of medical oncology at Tata Memorial Center, Mumbai, where he focused in wherein he focused in the specialized field of hematological malignancies and stem cell transplant. He has also been involved in CAR-T clinical trials. He's been member of ICMR task force for guidelines for blood cancers. He's also a very active supporter of patient education, patient advocacy, and supports better outcomes for patients. So with that introduction, thank you, Dr. Hari Menon, for joining
Thank
us
you.
today on this
Thank you,
series.
Aparna.
And we will get started because I think we have a lot of ground to cover. So let's start with what is CAR T cell therapy? What does it mean in lay language or in plain language?
So just start with what it's done. It's an abbreviation. So CAR T cell stands for chimeric antigen receptor CAR T cells. So antigen receptor T cells. So basically, it's what we call as an engineered T cell. Basically in the human system,
Mm,
the T cells are responsible for immune surveillance, especially against malignancies, and it tends to target the abnormal cells, which it identifies through various mechanisms for destruction, and that's how what happens in the normal immune surveillance that happens. Many cancers are amenable to this control by immune surveillance, but sometimes when it goes out of hand, you tend to manifest with cancer, and this is particularly true with hematological malignancies. So over here, when we are talking about a chimeric antigen receptor T cell, yeah, the cancer cells have incredible abilities to avoid the immune surveillance system, and so that's how they tend to survive. And what happens is when the I and this through various mechanisms, and in fact, the 2017 Nobel Prize was awarded to identifying these mechanisms as to how these cancer cells disappear. So the things have evolved, and here basically in chimeric antigen receptor T cells, every cancer cell has some sort of an antigen expressed on its surface, which tells the immune cells that okay, these are antigens that have to be targeted, and based on the receptors that are expressed on the T cells, the T cells are guided to this, and they target these cells and then destroy these cells through various mechanisms. But many a time, the CAR T cells do not express these receptors, or the T cells do not express these receptors in normal life, which are against the antigens that are present on the tumor cell. And so the idea of doing a CAR T cell is to make the CAR T cell express these antigens, and which is not in normal physiology, but it is artificially done in the laboratory through manipulation at the nuclear level and the genetic at the DNA level. Um, which is manipulated in the lab. And so you get some receptors. For example, you have like the antigen which is present on the lymphoma or the B cell lymphomas, like on the CD19, but the T cell does not have the receptor against to identify the CD19. So you make the T cells express through genetic engineering, through engineering to express this receptor on the surface, and that receptor, because now it's expressed, you give it back to the to back to the patient. You first extract the cells from the patient, manufacture these cells to express these receptors, and then give it back to the patient so that it goes back, expands, and destroys the tumor over here. So that's why, because it is not normal in physiology, so it is. That's why it's called a chimera. Yeah. So that's how the term comes, as chimeric antigen. So it's a chimeric antigen receptor. So you are generating an antigen artificially over here through manipulation in the laboratory.
Right. And once you've generated this, you said you extract it, do uh, the genetic modification,
Yeah.
and then you reinsert, is it, back
Correct. Yeah.
into the
Yeah.
patient?
We give it back to the patient. So it's basically harvesting the T cells that are present in the patient. So and you harvest the T cells, and then you manipulate that through what are known as vectors to introduce certain codes into the DNA sequence, which will allow for the expression of these. And these codes are responsible at the genetic level to express on the surface certain receptors. And once that code is inserted into the DNA, it naturally expresses that. And then comes the point of expanding the T cells in the laboratory, and you expand those CAR T cells. So when you expand all those, not everything is incorporated with the receptor. So you have a percentage of those. So you need to expand. And then once the expansion, then you know the viability of the cells, you take it and give it back to the patient. And once inside the patient, then the immune mechanism takes over, and again, it expands within the host or the patient's body,
Right.
and then it attacks the tumor. Yes, yeah.
Okay. So in kind of, because people who've been dealing with cancer, they understand
Uh-huh.
now terms like
Yeah,
targeted therapy,
yeah.
chemotherapy, immunotherapy. Is it a type of targeted
Yes, it
therapy
is.
or immunotherapy? What
It
would
is
it be called?
in by definition, it is a version of immunotherapy, basically. Because, but when we talk about in the strict sense, when we talk about immunotherapy, we talk about giving antibodies to
Hmm.
the patient, and then you stimulate the immune system within. That is, we call in vivo. Yeah, you stimulate the immune system
Right.
to
Right.
to do the job that it is supposed to do. So there are various mechanisms by which. So in a strict sense, it is immunotherapy, but these are live cells that you're giving. Yeah, these are
Hmm.
live cells. These are not portions of cells. These are actually live cells which are manipulated. So we would rather call this as cellular therapy rather than refer to it as immunotherapy. But if you say so, it is a part of immunotherapy, you can
Immunotherapy.
say so, yeah. We
Okay.
call this cellular therapy. So it
Cellular.
would fall into the same bracket as when we thought of allogenic stem cell transplants, where you're using the donor cells which are immune competent to do the job. So in a way, it is a type of transplant, only that because it is a patient's own cells, it would be categorized like an autologous transplant, right? That's the patient's own cells are being used. Yeah.
Right. Right. Um, and is CAR T cell, kind of, in simple terms, is CAR T cell therapy one treatment, or is it a category which has actually multiple CAR Ts?
So, so if we don't uh, for that particular for that targeting that particular antigen, it is
Hmm.
perhaps a one-time treatment. Yeah, so we will call it. But then there are various other antigens that can be targeted over here. Yeah, and uh, so if so far, especially in lymphomas, when we talk about, there is only the CD19 that has matured for use against CAR T cells. So currently, when we're talking about CAR T cells, is equivalent to talking for B cell lymphomas and also B cell leukemias, which expresses a CD19. So it is in principle, it's a one-time treatment. Yes, it is a one-time treatment that we do. But if you're going to in the future, who knows? Maybe we might have other antigens that we want to exploit, and then you can use a different type of CAR for that antigen. And nowadays we are also developing cards which are dual antigens. Yeah, it targets two different antigens within the system. Yeah. So as of now, CAR T cell is a one-time treatment. Yes.
So it's a one time and a one type treatment, is
Yes,
it?
one type. Yes, yeah.
Okay.
So there are variations of which we do what you call as bispecific antibody therapy, which is also in the strict sense effectively a way of what the CAR T cells are over here. But only thing over here is that you're using antibodies which have two targets. One limb actually targets the T cells, and the another limb targets the antigens on the tumor cells. So in effect, they bring the T cells and the tumor cell in close proximity, so that the T cells are able to identify and kill so those treatments which we use with bispecific antibodies, we call it, are actually multiple treatments. So it's not a single treatment. You have to, like how we give chemotherapy in multiple cycles, we give
Hmm.
treatment, whereas CAR T cell is a one-time treatment. Yeah.
Right. And we will come later to, I think there are now multiple CAR T products, so we'll come to
Yeah.
that later.
Yeah.
But if we talked of whether it's a single treatment or a category of treatment, and yeah, so I think that's next question. Are there multiple products for CAR T? Because you now start to hear different brand names even within India.
So
Um,
yeah, so they are basically what to say different what to say protocols that are used to generate antibodies, and various companies have come up with generating but the target remains the same. Yeah,
okay.
sometimes the vector that we use may be a little different. Yes,
Hmm.
to introduce the sequence within the DNA so that it expresses the vectors might be used. So, and also some of the types of cars that we use, for example, the way that it attaches to the linkers, as we call it. There are so many things as far as so many aspects to the structure of the CAR T cell. So there are various modifications in the way that the structure is formed, and so that what makes it different, like different drugs or different pills. So it makes it different. But at the end of the day, the target remains the same. So
Hmm.
when it comes to treating CAR-T for lymphomas, the target remains what we call the CD19 as a
19.
target. Now there have been sometimes some other CARs which are looking at CD22, but those are still not for recommended as standard of care. But CD19 has been approved, and in myeloma, you target another antigen known as the B cell membrane antigen, or the BCMA, and that is so you use a CAR to target the BCMA. So that's how the CARs are different. So as of now, we have myeloma CARs and we have lymphoma CARs, and targeting the CD19 and the BCMA. That is
Right.
for approved indications for for, for use in the clinical practice. Yes.
Right. So, okay. So, you talked of the fact that now we have B cell leukemia and B cell lymphoma are both
Yeah. Yeah.
in with
Yeah. Yeah.
CD19 as the
Yeah.
approved. So, are at the moment, if you look at it in terms of eligible for treatment, are those the only two category
Yeah.
of patients that are
So
eligible for this therapy?
yeah. So any tumor, any B cell lymphomas expressing CD19, because that you need a target, isn't it?
Hmm. Hmm.
Are candidates, and currently we are using CAR T cells only in it's approved for multiple relapsed or failed two lines of therapies in lymphomas. And it is maybe the trials are going on for its upfront use also, but it's
Hmm.
difficult sometimes to use it for upfront use itself, because when we treat a B cell lymphoma with standard treatment, we still encounter anywhere between 50 to 60% long-term cure rate. So it would be sometimes may not I mean, for a tumor that has almost a 60% primary cure rate with the treatment, we may not want to use it as upfront. But there are ways of trying to recognize tumors that are at high risk for relapses. So those are the indications where we might. The studies are ongoing for its frontline use over here.
Right. So right now they are for
Relapse,
relapsed or
yeah, relapse and
relapsed.
refractory setting. Yeah. Yeah.
Right. So can you just explain refractory, what it
So
means to a layperson? Yeah.
refractory can be two ways. Either it is a primary refractory or secondary refractory. So when you say primary refractory, the disease has not responded to the primary treatment which we offer, which is usually chemoimmunotherapy, chemotherapy plus using an antibody against the CD20,
Hmm.
isn't it? So,
Right.
that if it fails, and if the patient is called a primary refractory, then there are patients who relapse, and even at the time of relapse are still sensitive to chemotherapy strategies depending upon how soon they have relapsed. So we call it early relapses versus delayed relapses. So many of the people in the early relapses may not respond as well to primary chemotherapy, and then they fail to respond to the standard primary treatment, and those are referred to as refractory disease. Yeah.
Right. And you mentioned B-cell leukemia and lymphoma. So multiple myeloma is not yet approved
You
for
know,
clinical use.
no, it is. It is in the
It is.
international. Yeah, yeah, yeah.
Okay.
So I only said that
In
our indigenous product, which we are
right.
currently finishing the phase two, we have finished the phase two of that. Yeah, we have to await the results before we submit it to the DCGI for approval. Yeah. So, but otherwise, the myeloma card, the BCMA card, there are three different products that are available currently for use against myeloma, which target the BCMA antigen. Yeah.
Right. But in India, you're
No, it's
currently
not.
finishing the clinical trials with
Yeah,
the Indian products.
we have finished the phase two. Yeah,
Hmm.
and we are awaiting the results. Yeah, for that. And there is also another immuno act, for example, over here. That is the phase one two study is ongoing actually. For their cars are different. They also are having the BCMA car for myeloma, and that is going on. And that the trials are ongoing, and they have
Okay.
embarked onto the phase two. Yeah.
Right. Right. Um, and in clinical use, not in trials, but in clinical use, approximately how many patients are, kind of undergoing CAR T treatment in
So I
India?
can. So if they have to undergo a CAR T cell outside of that of a clinical trial in India, they have been either going abroad for their treatment to the United
Hmm.
States or to Europe, and or to China. There are a lot of in China. There are a lot of centers which are offering a routine CAR T cell therapy. In fact, there are exclusive centers for CAR T cell
Hmm.
therapy alone in China. So, in fact, I've had a few patients who have done their CAR T cell following up with us over here. But currently, outside of a clinical trial, it's not available in India. So I can only talk about the few patients that we have finished, almost 24 patients, which is part of the phase one, phase two study, which is part of a multicentric study, which who have finished. The remaining are a few who have undergone treatment, who have had the resources to go, because this is a fiercely expensive therapy,
Right.
not feasible for an average person to go through with, and the costs are significantly higher. And we project that the cost in India would be less than one third or probably one fourth the cost that is the cost abroad. Yeah, for the CAR T cell. Yeah,
Which is still
yeah,
quite significant,
it is still
right?
expensive. It is still expensive. Yeah.
Right. And in terms of the data, what is the success rate, or how are you, looking at the outcomes of CAR T?
So, we talk it. I mean, if you're talking about our own cars over here in India, we have had fairly good success, and the success, especially for the B cell lymphomas, which is the T cell, which is a car which has been um, uh, what to say, manufactured by ImmunoAct, the group in the which is a collaboration between Tata Memorial yeah, and IIT Mumbai, and now it's become a company called ImmunoAct over there, which is doing the cart. They have had a good, excellent, good success rates, which is probably keeping in with the international data, but the data is still maturing in terms of long-term outcomes. And I would say that the results have been probably a little better with the lymphatic leukemia group of patients, and not as much as good for the B cell lymphomas. But having said that, we are talking about patients who are very refractory to disease, and it is more or less comparable with the data from the international database on CAR T cells for these indications. The data for myeloma cells for myeloma is very promising. In fact, I had presented the data at the Society of at the SACT meeting more recently, the phase one data, which is very impressive in terms of the outcomes. But um, uh, and the first patient has completed more than 1.5 years now, um, post start of treatment. So it looks promising, but I think we should never talk on all the phase one data until we have a larger cohort over there. But in terms of efficacy, yes, I think it's very good. Yes,
Right. And people kind of always look at a new therapy with a lot of hope, right? So,
yes.
is CAR T a guaranteed cure? Or is it more because it's also an expensive
Yeah.
option? So, what should they be looking at and considering? And we'll
So
come to that in in more detail at the end, but just in terms of the
there
perception.
are so when we talk about CAR T cells, there are a lot of knowns and unknowns over here, and there a lot depends upon how the immune system is going to work and how well it is going to coordinate in terms of, and how even for that matter, how responsive. Just because you are targeting an antigen on the tumor cells doesn't mean that it is going to work. But it is there are a lot of other factors, like for example the microenvironment of of the tumor, or even also the immune competence of the patient also,
Mm,
in terms of and the extent of the disease. uh, for that matter, any cellular therapy, whether it is an allogenic stem cell transplant, or whether, yeah, it is a CAR T cell therapy, or whether it is a targeted therapy, they all work better when the volume of the disease is low. So when you have a very high volume disease, it is likely that they may not respond as well, because there are a lot of other factors that come into play. But there is, having said that, uh, we go with the understanding that this is one of the ways to treat B cell lymphomas, especially refractory disease, and we go with the understanding that it has to work, but there is no guarantee that it will work. Yeah. And more important than whether it will work is that whether the responses can be sustained over a period of time. Yeah, so there is something called the persistence of the cars in the system to continue to do the work that it has to do. And in terms of how responsive that, I mean, because as I said, there is a great ability for the tumor cells to escape the immune response also, and so in those situations, there is an escape. And then there are entities where there is a fatiguing of the immune response also, which will
mm,
also allow for the tumor to grow. And it also depends upon how aggressive the tumor is or how fast the tumor will grow. And that also has something. So suppose it overwhelms the immune response, the tumor growth itself overwhelms the immune response. So it's very little that So you are dealing with a very, very strong opponent, and and it just trounces the effect of the immune system to actually control the disease. Yeah.
Right. So what is the data that we have so far on CAR T showing in terms of how long does that persistence
Uh,
of
yeah.
the CAR last?
When you
And
look
for
at
what
it,
percentage of patients?
so if you look at the global data, it ranges anywhere, the responses can range anywhere between 40 to 80% responses, but then that's responses are not always translating into benefits, so the persistence. So we have long-term outcomes which are somewhere between 50 to 60% for all these CAR T cells. But I cannot say the same as of now because our data is still not fully mature.
Mm,
But the long-term follow-up from the Indian CAR T cells, especially in the CD19, if I'm not mistaken, it's a little in excess of 40% long-term results. So, but I think it will be only justified for us to commit on to that data after a little bit more of a longer
mm,
follow-up on these patients. Yeah.
right, right, right. So approximately for the Indian car, what is the oldest or the longest it has persisted? Do we have any kind of,
Um,
you know,
I'm not too sure, but I think it's yeah, when I asked my colleague, it was more than 2 years now, at least more than and in excess of 2 years. Yes, yeah.
right, right. Okay. And also there's a
But the
question,
problem is that
yeah.
we can never predict as to who is going to respond. Yeah, we
Mm.
can just hope. Yeah, the primary thing is to get a response and then to see how they do well. But usually, the adage is that if you have a response, then it is likely that he is likely to go on to sustain that response.
So is there a mechanism um, to assess whether a patient should be eligible or like you do a geriatric assessment, right? To
Yeah,
say that,
yeah,
okay, this
yeah.
person, do we have that mechanism
So,
or is there
so
a plan
unlike
to look at that?
So unlike when we give chemotherapy, where we expect patients um, uh, to have varying responses in terms of tolerance to the
Mm,
treatment,
mm,
that doesn't hold so good for. So even elderly people, even we have, the literature would say patients above the age of 80 also can undergo a CAR T cells because it is not so much the toxicity that is induced, like we brought the chemotherapy, which will sort of cause a compromise in terms of um, increased morbidity associated with the treatment. That doesn't happen with CAR T cells. So either you can get it through uh, yeah, we have to see whether we can manufacture the CAR T cells and if the patient has the target antigen expressed on the T cell, on the B cells, which is what we're talking about. When I'm talking by default, I'm talking about B cell
Basal.
lymphomas. Yeah.
Right.
So then they are all candidates for undergoing. So unlike when we give chemotherapy, practically any patient is eligible for a CAR T cell option for treatment, provided they
Right.
express the antigen. Yes. Yeah.
Right. Right.
Provided we
Um,
can manufacture and provided we can also manufacture. It's not, see, there is a point over there also. We might harness the T cells, but we may not be able to manufacture the chimeric antigen receptor T cells in the laboratory. And that has got a lot to do with the kind of treatment that the patient has received earlier also. Even sometimes the kind of chemotherapy that the patient has received earlier may also impact the ability to manufacture the CAR T cell.
right. But do we have now kind of a listing of, is it the specific chemotherapy protocols that make a
Yeah.
difference or?
Yeah, it does. It does because many of especially the low-grade lymphomas, which we call as low-grade lymphomas, they receive a certain kind of drug known as bendamustine, and the studies have shown that when patients receive bendamustine, it becomes difficult to harvest the T cells and manufacture T cells over there. So when a patient has received bendamustine, we wait at least for a minimum of 6 months before we attempt to target harvest the CAR T cells. But then sometimes that 6 months may be too long for a patient's survival itself in terms of in the presence of an aggressive disease. So these
Right.
things are criteria that come into play. So there is a lot of planning that is required if we are looking at a patient as a potential candidate for CAR T cells in the era of availability of CAR T cells for patients treatment. Yeah.
Right. And there's a quick question on, are there CAR T trials happening for pediatric ALL, acute
Yes,
lymphoblastic
yes,
leukemia?
yes, yes. I mean, that was completed also at Tata Memorial. It was part of there were two wings for the treatment. One was for lymphomas, and another was for acute lymphatic leukemia. And acute lymphatic leukemia is more common in the pediatric age group. So there was a separate trial, which was a phase one study for pediatric ALL patients. Yeah.
Okay. Um, so, you said that it's not as, you don't kind of associate the treatment with the kind of toxicity, etc. But are there any side effects that
Oh
patients
yeah,
should expect? Are there complications that they should be kind of, you know,
yeah, yeah,
aware
yeah.
about?
Oh yes, there are a lot of problems. So it's not a walk in the park actually, as far
Mm,
as CAR T cell concerned, and there are unique problems that develops. And this is like any other allogenic stem cell transplant. Whenever we are trying to manipulate the immune system, it is not like as we might think that we can control it, but we can never control the immune system. And what we think that we know is probably only the tip of the iceberg as far as the way the immune system works. Yeah. So, so when we talk about CAR T cells, as such, these patients are immunocompromised by virtue of the disease that they have and the multiple treatments they have received before. And then over and above that, we are trying to uh, uh, induce an immune mediated response, which will also cause a lot of suppression for the disease. And we are actually targeting the B cells, which are actually the cells. You must understand that even the normal B cells, they would also express CD19. You understand? So there might be what we call as a destruction of many of the normal B cells, also what we call as lymphopenia that develops, and it's the B cells then in the body that actually secrete the immunoglobulins that protect us from various infections,
mm,
especially viral infections. So when we talk, and also when we start with the CAR T cell therapy, you need to have, in order for the body to receive the CAR T cells without too much of a problem, you need to create an environment which suppresses all the B cells as much as possible. So we give chemotherapy. So there itself, initially, you are having some amount of immunosuppression that happens during the first 1 to 30 days. Then, when the CAR T cells are introduced into the patient's body, it stimulates an immune response, which will secrete what a lot of what are known as cytokines, etc.,
mm,
which in itself will induce an immune suppression in the body. And then later on, because of the prolonged suppression of the B cells, you can get a reduced amount of immunoglobulins in the body, which makes you prone to infection. So, over a period of time, at various levels, you have a sustained immune suppression, which makes you prone to infections. So that is where the challenge lies in treating CAR T cells. How much is the cytopenia, or how much is the neutropenia that develops over here? And also, we tend to what do you call have so much of low immunoglobulins that we have to artificially give IV immunoglobulins to the patient to sustain the levels for some degree of passive immunity so that they don't develop infection. So the challenges, while it's an effective therapy, the challenges are actually how you can handle the problems after the uh, which we have to
after
expect
that.
are going to be cytopenias, that is low blood counts, low immune system, low immune responses, and
Mm.
increased risk for infections. And sometimes you can also have immune-mediated immune effector cell neurological symptoms, what are known as ICANS in these patients, and yeah, and this is particularly true also in myeloma CAR T cells, where you are having certain targets in the basal ganglia, for example, and that also expresses what is known as the BCMA. So it's a common target. So sometimes you can get these neurological symptoms that happens in these patients, which are also immune effector mediated. So there are various problems that it develops, and but the problem is that we still go ahead with it, and you cannot predict who is going to develop the problem. And
Right.
who is
Right.
not. Yeah. Yeah.
So in terms of the neurological symptoms that develop, are you saying it's a bit like, they could end up getting behavior issues?
Yes, yes, yeah. So the
It's
one of the manifestation of what's known as ICANS, immune cell effector, neurological symptoms, are basically psychiatric manifestations or yeah, so those are the ways that so we always monitor these patients, and usually this happens not in the early phase but probably in the second week or so after, but generally manageable. It's important to recognize these, and then they are managed with steroids. And now the way to manage these things are also evolving, and again
mm,
these are not predictable. It can happen to anyone on some of the pay. For example, none of the patients that I was involved with ever had an ICANS actually, or
mm,
if they did have, it was very very low, and they just changed. So, but it is a problem. ICANS is a problem. Delayed cytopenias are a problem, and immediate and infection rates are a problem. So sometimes the patient might get treated and get cured of the disease, but you end up having to manage all the infections for a long period of time. Yeah.
right. So you mentioned if there is ICANN, it's treated with things like steroids. So you're not
Yeah.
you're not expected to go
One of the
to
first.
a psychiatrist for, your
Oh no 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 no
typical
no. So that's
psychiatric
what.
drugs, psychotropic drugs.
So no 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 no
No.
no. So
Okay.
because this is immune mediated, isn't it? So
Right.
you need to treat that the response which is immune mediated, and one of the front line is to start with steroids in these patients, and also sometimes it could be due to the cytokines and the tumor. So you use antibodies like tocilizumab, which is used in these situations. It's important to recognize and also grade the level at what and to what extent you need to go. So you have the frontline defense, then you have the next line of defense, etc. That's the way it is. Yeah.
Right. Right.
Yeah.
Um, so in terms of, and when you say that patients will need to be after CAR T will need to be careful in terms of, staying in a immune, I mean, a safe environment, right? In a
Yeah.
way. So, how long is that period? Do we have
That is
an
unfortunately not predictable, but we don't ask for like how like for example an allogenic stem cell transplant,
mm,
because we don't give so much of an intensive chemotherapy in uh, when we start with the CAR T cell. It's actually called a lymphodepletion therapy, whereas in an allogenic stem cell transplant you give myeloablative, that is you ablate the bone marrow. So the patient
right,
is a sit the usually the patient is a sitting duck for about 15 to 20 days, where any sort of infection just passing along it can be a cause for very severe morbidity and mortality also, because the patient can get that infection so easily. But that doesn't really happen. But we are probably a little careful for the first 10 to 15 days. And if the patient does not have too much of a problem during those 10 to 15 days, then they're back to what they need to do. And we don't, I mean, we do say that you take precautions like wearing a mask and avoid getting an infection as much as possible. Don't go look at getting exposed to extreme weather. all those things. But we don't say that, okay, it should be an isolation. No, like how
Mm,
we would have in an allogenic stem cell transplant, we impose some isolation for the
correct,
first
correct.
3 to 4 weeks until the graft gets in and starts functioning. We don't do that with CAR T cells. So while infection is a problem, it's not anywhere close to what. But the problem in CAR T cells is the sustained susceptibility to an infection over a period of time. But that can be variable for different patients. Not everybody develops it. So we don't ask for strict isolations for these patients, not at all.
Right, right. And do they need to, like, because you mentioned the allogenic stem cell transplant where you need to redo all of your vaccinations, etc.
Oh, yeah.
Is
So
that
that,
required?
yeah. So generally, most of these patients are vaccinated,
Mm,
and but we do look at revaccinate because we have only sort of modified one particular aspect of their immune mediated response. We are not modifying their entire immune. But having said that, we do, if the patient has not been vaccinated earlier, we do advise for the regular vaccination, like the influenza vaccine and all those things. And if the patient has not been vaccinated for pneumococcal infections, we ask for the vaccines for that. And that is usually done about maybe around 6 months after the 6 months to even 1 year. There are various schedules for that. But the one thing about vaccination for all these, we do it, but the for any vaccine, you should be able to mount a response like an antibody
mm,
based responses. And over here you have already depleted the B cells which are responsible to generate those immunoglobulins, so you may not get the kind of responses that you desire from a vaccination schedule in these patients
right,
because their baseline immune the B cell component is sort of suppressed or um, uh, relatively inactive actually.
right, right. Very quick question. Can the ICANN be compared to chemo brain?
Hemobrain is something that one develops long after the chemotherapy, and yeah, but it's not the same.
It's
Yeah,
not the
immune
same.
effector field, it's not the same. It is more of a confusional state that happens in ICANS, and in the chemobrain is more of a broad kind of picture that we see
Yeah,
much after the chemotherapy is this thing. But ICANS is an entirely different. It's an immune mediated response. Chemobrain is not an immune mediated response.
right, right. So, in terms of when you look at the data that's out there, what are the common causes of mortality post-treatment? Is it just that um, the treatment didn't sustain, or
Yeah.
is
So
it
most of the
that there
time,
were
most of the time,
infections?
it's disease progression and infections. Yes. These are the two main causes. Sometimes immediately during a post-transfusion, post-infusion of the CAR T cells, you can get acute reactions like cytokine release syndromes, which again is because of the cytokines related released by the CAR T cells when it attacks the tumor cells. And there is a big inflammatory response that is created, which allows for which causes a lot of hemodynamic compromise and hypotension, capillary leak, and pulmonary edema. And hypotension, sustained hypotension, which can be quite refractory. So those are life-threatening. So those are the acute causes for morbidity and mortality associated with CAR T cells. Delayed, of course, causes for morbidity is, of course, infections. Yeah.
Right, right.
And cytopenias, yeah. And the cytopenias may continue to remain lifelong also for the patient.
Wow,
Yeah.
right. So, you talked of the cost of CAR T in India kind
Yeah.
of expected to be one third to one fourth of what it is international. What is the
Yeah.
number we are looking at, if there's anybody in the audience who doesn't know that number?
So various companies have the see that the cost of the it's a very complicated manufacturing process, and it's also the cost. Much of the cost goes into the manufacturing, and also the vector that we use. The viral vectors are expensive, and they have a patent on that. Various companies have a patent, so there is a cost associated with it. And the manufacturing is also very stringent, isn't it? Because
Mm,
you're using live cells outside and you need to maintain their integrity. And so the lab requirements are quite stringent over there. And there is a lot of reagents that are used, and also the environment within the lab you need to create to produce the cells so that you are getting a cell that is we manufacture those cells and you are going to bring out the viable cells, and it needs to have the same functionality to do the job that it is supposed to do. So it's an expense. So when we're looking at the cost, so on an average in the West, it's like around 250,000 US dollars. That was a little while ago. I'm sure it is more right now. And also, they also say that besides the $250,000, even they have an additional cost that happens for the supportive care that is required.
mm,
So it can be close to around 400,000 to $500,000 dollars to do that. Whereas in India, we are talking in terms of about anywhere between uh, 35 to 40 lakhs for the ImmunoAct ones that we talk about. But I'm sure that that cost is going to come down over a period of time, say probably to the tune of about 20 to 25 lakhs. Let's say. And now there are Immunil, which is also manufacturing the CD19 car. They had a very it's about 30 around 40 lakhs or so to do the CAR T cell. But one must understand that this is for the manufacturing cost. You may have to give allowance to also for the supportive care that is required.
correct.
Immunoglobulins are expensive, and we need to give it as and when it's required. The supportive care, like using tocilizumab, is expensive, um, but it's nothing compared to what we some of the cost of other drugs. But still, it is expensive, and we may have to use it repeatedly, isn't it? So, but
Right.
the cost for immunoglobulins and the supportive care, antibiotics. Sometimes you may have to give blood product support like platelet transfusions, and all these things will have to get into. And you can end up with several immune related toxicities, like how we call as, which will be akin to what we get in
Mm,
rheumatological
correct. That
problems
was my
like,
follow-up
like
question that,
yeah,
with all this
like
immune stuff
yeah,
happening,
you can
while we
develop
expecting immune compromise, but we could
and
also end up with
yeah,
autoimmune conditions. So,
autoimmune conditions. So you get with a lot of autoimmune issues can manifest lung toxicity, renal toxicity, and liver toxicity, which is induced by the immune mechanism. Yeah, and there have been some concerns about CAR T cells in the future because you're using a viral vector to the thing. So whether that itself can become oncogenic and induce. So there have been reports of unusual T cell lymphomas, the T cells which we give as part of the CAR T cell therapy may become malignant. And this has been identified because the viral vectors in those malignant clones have been identified in those malignant clones. And so that's why they know that it has been derived from. But these have been case reports that have developed, and I think the data has to mature for that. But this is also something at the back of my mind, which may be a problem in the future.
right. So does that also mean that as a, when we look at the team of doctors that will support a patient who
Yeah.
undergoes CAR T, it's
Mhm.
not just the oncologist, but will also may need a immunologist, or we don't expect that to.
It would be a good idea to have an immunologist on board over here, but generally the hemato-oncologists who are dealing with transplants on a routine basis uh,
Mm,
will be able to manage the issues that develop. But see, it's more important to recognize the problems earlier rather than the treatment, because the treatment boils down to something early. So the faster you recognize a problem and initiate a treatment, the better are the results. So for that, you need to have the knowledge and the experience to deal with this. But So as we would say, when you take CAR T cells, when you develop an ICANS, you don't call the neurologist, but you need to have the treating physician come on board to understand what the problem is and take measures. So you don't have the neurologist to tell us that this is ICANS. Yeah. So that's the way we are. But always, as we go along the line, it will be useful for them also to be engaged in this entire enterprise. Yeah.
Correct, correct.
Because as of now, we only manage all these issues.
Yeah, but as the number of patients increase and, given that patients are traveling long distances,
Yeah,
etc.,
yeah, yeah, yeah.
and often in an Indian context where we are not very referral driven, patients might end up going somewhere else because,
Correct.
they think that it's
Yeah,
s-
yeah.
so
So educating the patients on all these things is very important before we start. Yeah.
correct, correct. Um, and in terms of, currently, how many centers in India are offering CAR-T?
There are several centers, but the manufacturing is done only by a few, like ImmunoAct and Immunil, and maybe in the future, and when once it's approved by Origin. And there
Right,
are several other companies which have the pharmaceutical industry have come are looking at setting up manufacturing facilities for CAR T cells in India, and that is what the way it is. So. I mean, I would not have expected what we are doing today 3 years ago.
mm,
And so I guess in the next 3 years or 5 years, you would see a lot more companies coming forward offering CAR T cells or manufactured CAR T cells. And now we are embarking on to the next level. In fact, we would be embarking on to a trial where we call as off-the-shelf CAR T cells or allogenic CAR T cells. So that's a different way of manufacturing CAR T cells, where we have a healthy donor to provide the T cells. So it is akin to doing an allogenic stem cell transplant, where you
mm,
are using a healthy donor's T cells and manipulating them for acceptance to the donor cells in terms of like how we do for an allogenic stem cell transplant. You try to do a matching for them.
right,
And over here, it's not like as we do the HLA matching, but we
mm,
sort of manipulate the CAR T cells to knock off certain receptors on the cells through what are known as CRISPR technology, and try to take off some of the receptors that are present that will recognize, so that it becomes accepting to the donor, I mean to the recipient from a donor cell. So these are called off-the-shelf CAR T cells, and that is something that see might be the case in the future. So the one of the issues with the CAR T cell therapy is manufacturing time. So if I were to plan a CAR T cell for a patient, I have to at least plan anywhere between 6 weeks to 8 weeks in advance, so that the patient can be planned for a harvesting, and the manufacturing process takes anywhere between 2 to 3 weeks. Now it is on an average, our CAR T cell manufacturing is about 15 days, 15 to 18 days, but it can be more. And
mm,
uh, and sometimes the tumor may not weigh and will not
will not wait.
last out that period of time. So that's one
Right,
of the deficiencies. So many of the B cell lymphomas currently are looking at using bispecific antibodies, which is targeting against it, but we are using off-the-shelf antibodies, which does effectively the same as a CAR T cell. And so and the data would say that they are almost as uh, effective as the CAR T cells in on a patient-to-patient basis, definitely. So, but again, it's a very expensive, and it's a treatment that you can't stop with just one treatment. So. It's like giving chemotherapy. You need to give antibodies at regular interval, and there's a schedule for that. But it's also an effective. treat, doing exactly the same thing like what a CAR T cell would do.
But then that would come with issues of things
The
like
same, all the same,
GVHD.
all
No,
not
not GVHD.
you're talking about
If you're getting,
allogeneic.
from the other donors, would we
Oh,
end up?
not so much for the bispecific antibodies, because bispecific antibodies are just immunoglobulins, isn't it? You're having
Right,
an immunoglobulins
right.
which have got dual receptors on their surface, one for the T cells and one for the tumor antigen. But yeah, for allo stem cell, yes, it is a possibility, but
Mm,
it is to decrease the possibility that you're knocking out certain of the antigens on that to make it more conducive. These are still in phase 1 studies. Yeah,
phase one studies. Okay.
yeah.
Couple of quick questions before we come to the big question that I have really. One is, do you see CAR T as a standalone therapy or a complementary therapy along with transplant?
So,
So that's
so many of the patients, especially when you're talking about acute lymphatic leukemia, many of the patients underwent an allogenic stem cell transplant post CAR T cell.
mm,
So then you would probably look at that as a bridge to therapy, bridge to a transplant over here. Uh, but we rarely do allogenic stem cell transplants in lymphomas. Yeah, it's almost exceptional for us to do an allogenic stem cell. So for yes, it is you combine an allogenic stem cell transplant with CAR T cell therapy in lymphatic leukemia, but that may not be the case always because you have long-term results for acute lymphatic leukemia even with the CAR T cell therapy alone. Yeah, so
right,
that's also an evolving thing um, as far as CAR T cell is concerned. Yeah.
right. And can CAR, I think probably the answer is no, but can CAR T be developed for administration in daycare setting?
Of now, no, because you can, of course, you can give the infusion in a daycare. It just takes 15 minutes to give the infusion of a manufactured CAR T cell. Uh, but we are looking at problems that develop probably a day or
Right.
two before. So and those things can be quite sudden. So we prefer to have the patient in at least for a week post, just to be sure that they don't develop any which needs immediate attention. Sometimes
Right.
patients can end up because of a hemodynamic compromise with severe hypertension and will require inotropic support, which can only be given in an intensive care unit. For example, when we did our phase 1 study for all of our patients were at the ICU because we needed to know how we need to be ready for any of the problems that develop.
Right.
So as of now, we don't anchor, even for that matter, when we are doing bispecific antibody therapy, for the first few cycles, we admit the patient. But in CAR T
Right.
cells, it's only one dose. Yeah.
Right. So, if a patient is discussing with their doctors, and the doctor suggests CAR T, or the patient goes up and discusses CAR T, what questions should the patient be asking the doctor? Or, what are the answers they should get before they decide on going for a CAR T?
So one is whether sh- whether all other options of treatment have been exhausted. Yeah. So if that has been exhausted, certainly this is because this is entirely different from a chemotherapy kind of a protocol, isn't it? So if they are refractory to chemotherapy, then they certainly look at. And then for example, now we are talking about lymphomas and leukemias. So not all lymphomas. For example, if you have a peripheral T cell lymphoma, they are not amenable to any T cell lymphoma. For example, even though you use the T cells to do the CAR T cell therapy, any T cell lymphomas are not amenable to a CAR T cell therapy. Similarly, myeloid malignancies, yeah, so they like acute myeloid leukemias, etc. They are not, or for the matter, any myeloid tumors are not amenable to. So
Right.
we need to identify who's a candidate for that. And if you are having a B cell lymphoma, which is refractory disease, yes, they are potentially candidates for going for a CAR T cell. And one should be prepared their general condition should be reasonably okay. They should be time enough for us to be able to manufacture the CAR T cell so that it can be given in a reasonable amount of time. Because if it's a galloping tumor or a galloping disease, um, immune-mediated therapies like a CAR T cell therapy is unlikely to work over there.
Right, right. Okay. And one final question. How, what are the CAR-T trials that are currently ongoing? How many of them approximately, and how can patients consider joining these?
So currently, the myeloma CAR T cell is currently in India is closed for accrual.
Mm,
I think the myeloma CAR for ImmunoAct is still ongoing, and there are specific centers, and it might expand to as part of the phase two. It might expand to involve other centers. The CD19 CAR is freely available and for any patient, and there are multiple centers in the country who are part of the program who receive the CAR T cells from either ImmunoAct, and also more recently I had my colleague who underwent CAR T cell therapy from Immunil. So I was under the impression that Immunil is not very active right now, but they are also one of the organization or the companies which is manufacturing CD19 CAR. And I think for them also the BCMA CAR is also on the anvil, but I'm not sure whether the clinical trials have started. So currently, there are no clinical trials per se ongoing for myeloma.
mm,
There might be one for ImmunoAct, which is probably only limited centers are doing it as part of the phase one. If I'm not mistaken, the phase one is over and they're looking at completing the phase two. Other than that, there is nothing else. And now I have sort of our one of our centers, part of many centers, is embarking onto an allogenic CAR T cell trial, which is the first in human actually, and we've just submitted our the project to the IRB for approval. And once that comes in, we anticipate that sometime later part of this year, the phase one study may be launched for that.
right. Thank you. Thank you. So, I think with that, we pretty much have come to the end of our time also. So thank you so much, Dr. Hari, for,
Oh,
walking
my
us through
pleasure.
this. And I think the few key takeaways for me were that, CAR T is not the answer for all blood cancer patients. So, it's a decision to take after considering all options out there and having a detailed discussion with your doctor. And I think Dr. Harimanan also talked about what questions and how to have that discussion, which was very useful. And also factor in the care required, right? Because while it's a one-time treatment, but it doesn't end after that treatment. So, factor in all of that, even in terms of not just the cost of the car itself, but also the complications that could happen, the medications that are required, the supportive care required, etc. So, thank you so much,
You're
Dr.
welcome.
Hari Menon,
Thank you. My
for
pleasure.
taking your time for this,
Thank you,
and
Aparna.
I'm sure this has been a very useful session for all of our viewers.
Thank you. It's my pleasure. Thank you. Thank you very much.
Thank you.
I enjoyed being part of the discussion. Yeah. Thank you.
Thank you. Thank you.
Thank you.